We are live now, so let me share the slide. For the next 2 hours or 3 hours, we are going to learn nursing management. I remember in school, nursing management was a whole semester course. Okay, so those of you who are writing NCLEX and those of you who are writing other exams, as a nurse, you can't write any licensing exam in this world without having or meeting questions on nursing management, on nursing care management. Yes. So nursing management of nursing care. We go toward we have our group. Okay. So let's say this is the ward environment. And these are the patients on their beds. Okay. 2 seconds. Let me make my admins. Right. So these are the patients and these are the nurses over here. Okay. The nurses are working with the patients, their families, and whatever their siblings. Okay. Yes. Whatever care we are giving to the patient, that care was planned by someone. That for nurse A to work on patient A, the assignment was done by someone. Okay. Yes, we go to work to treat or manage patients, but the patient you are managing, whatever you are doing, you are working within a defined scope, which was done by someone. Okay. So what we are going to look at, or what we are going to learn today, is not the care you are giving to the patient, but the care you are giving to the patient within which scope and who designed that scope and what is the guidance or the principles governing that scope of practice. That is what we call management of nursing care. Yes, nurses go to work to care for patients. This care we are giving to patient, who manages that this care is perfect. We don't have any problem with anybody. Nurses don't have problem with patient relatives or patients. Patients don't have problems with their colleague patients. Relatives who come for visits, they don't have problems with other patients or other relatives or nurses, okay, or the other staff, paramedics on the ward, okay. Yes, so that is what we call management of nursing care. Okay, yes, this is a 24 model session, and every day I'll try my best to do 5. Okay, like I said, nursing management is a broad topic, it's a whole semester course. Okay, like 16 weeks course, but I'll try my best and take every day. We shall go like 5 or 4 models, then we finish. Once you are done with this, every question that will come under nursing or management of nursing care, you just answer it. And after this session, you realize that this question I met it. Why was I not able to do it? Yes. So this is what I want you to count yourself blessed to be part of this page. My name is Paul Bright. I'm your registered nurse. This is a free page. I'm teaching nurses. Okay, so Yes, if you're going to write an exam, healthcare, you're going to write. I don't teach because you are going to write exams. I'm teaching because I want you to be a nurse, a nurse or a best practitioner in your field. Okay. Yeah. So that is it. Please, everybody is watching. So when you join, you quickly off your camera so that you don't draw attention to yourself or your room. Okay. Right. So let me make the slide a bit bigger. So this is a major category in nursing. Nursing management of care is a major category in nursing and focuses on prioritization, delegation, leadership, ethical practice, and patient safety. So like I said, we are going to do models. So model one, we'll talk about introduction of to management of care. Then model two over here, prioritization in care. And I have developed an acronym. And if you grab this acronym, you are done with prioritization. Henceforth, you're not going to get any wrong in any prioritization question. Okay. Then model three, and it goes on. I mean, is a long page. Okay. So grab it. I'm going to make it fast because this is a slide. You get a slide, you get a video. When you get it, go back. If you don't understand anything, drop me a question in the chat box, and we are going to help you to understand it. So, what are the objectives we are looking at under the introduction? Understanding management of care categories. There are different categories. Yes. Okay. Then review the nurse's role as a leader and a manager. Do you know on the nurses at the ward, we have a leader and we have a manager. There are two different roles that people's attention have not been drawn to that. Yes, today I'll show you who is a leader and who is a manager because we are dealing with what? Management of nursing care. Okay. Then apply the nursing process in what management. Nurses, we work with a process. We call it nursing process, the apply. Yes. So we are going to apply it to management. Okay. So we have the NCLEX blueprint. Those who are going to write NCLEX, you have a blueprint. I've added it. So when you get a slide, just go to the view. We'll also look at what the nursing process. Join, then you mute yourself for us, okay? It means I've made you a co-host. So regulate the noise in the background because we are recording it. Okay. So we are also going to look at the clinical judgment models, the leadership versus management. So this is blueprint. When you take NCLEX, those of you who are going to write NCLEX, because we have nursing students on the page too. So the nursing student, I think this one is not going to benefit you. Okay. But those who are going to write NCLEX, this is the whole concept about NCLEX. NCLEX deals with what the four major categories or the client needs framework. We are looking at the safety and effective care environment. This is a big need for every patient you meet. Okay. We are also going to look out for, so we have subtopics under them: management of care, safety and infection control, health promotion and maintenance, all these ones. You see the questions that will be coming out of it. We have the psychosocial integrity, okay, and all the physiological integrity of patients. We're looking at the pharmacology aspect, okay. Yes, then some other examples. Example, like a patient will come A patient suddenly develops what? Shortness of breath after surgery. So ankles, this is a physiological what issue. A physiological adaptation issue. Yes. Then we also have the NGN. This one is just a brush up, okay, for those who are going to write NCLEX. Then NCLEX will come in and tell you the test taking priorities. So we have the ABC, the Maslow's, the acute, chronic, and all those stuffs. Yeah. Okay. Yeah. So another question under the NCLEX framework. Okay. Who should the nurse assess first? This is a priority question. So after everything you understand, then we've got the nursing process. The nursing process is a systematic method used to provide individualized patient care. So we have the assessment, and under assessment. Assessment, we are collecting data, okay, from head to toe. So what are some of the data? Some the patient will say, some you will see it or you observe it. Okay. Yeah, either through machine using equipment or machines to collect the data, or using your hand and other stuff, percussion, palpation, and all those stuff to collect the data. So this one is an assessment. Okay. Then we also have the type of assessment. We have the initial assessment. This should be done by nurses. We have several types of assessment. This should be done by what? Nurses. It is performed on admission. The patient has come, or you went for duty. You've never met this patient before. Your initial assessment. Okay. Then we have focused assessment. On focused assessment, we concentrate on the body systems. Okay. So system by system assessment. So you do the lungs, the central nervous system, and all those stuffs. Okay. Then we have emergency assessment. It is performed during life-threatening situations. Somebody is crashing because it's bleeding, is getting hypovolemic shock. We do emergency assessment. Somebody is getting atrial fibrillations. We do emergency assessment. Airway, type 1, type 2, respiratory failures, emergency assessment. The traginess has gone to an accident scene, emergency assessment. Okay. You can't go and do initial assessment or focus assessment on trage area. We do emergency assessment. It's performed during life-threatening situations. Example, airway assessment during respiratory distress. That's it. So in nursing, assessment always comes first. You know the different types of assessments now, so you should know which one to go for before you do your diagnosis. Okay. If you don't have data, you can't diagnose. If you don't have data, you can't diagnose. So if you don't do assessment, you can't diagnose to know the nursing diagnosis. Okay. So some of the data we collected were fever, productive cough, crackles. Then we will do our nursing what? Diagnosis. After diagnosis, we plan. Okay. We plan. So all these ones, why are we bothered about it? We are bothered because the nurse is the manager on the shift. Okay. And among the nurses, if we have 5 nurses, okay, if you've got 5 nurses working on the shift, one will be chosen as what? A manager. That's it. Okay. So the manager should ensure that the nurses under him or her does all their work in their practice. They will go by what? The nursing process. They will assess. Okay. You can't just go and give somebody paracetamol because the patient complain of headache without assessing to know what the nature or the character of the pain. Okay, so the nurse manager will come in and say that no, you did not follow the right procedure. So please follow the right procedure. Okay. After you've given paracetamol, your documentation, you did not go by the right way. So the nurse manager will come in and assess your care. or your documentation. Okay, so that is what we call management of nursing care. You understand? Okay. Then we have implementation. Under implementation, so we've got the dependent and independent interventions or implementations. Okay. We say dependent or independent. Yes, some of the implement or interventions, the doctor must give an order before the nurse intervenes. That is why we so the nurse is depending on the doctor to know what to do next. We call that one dependent interventions. Okay, so a nurse will do something or will act, will intervene. Yes, she was helping a patient. Okay, but a problem will arise. We will take the nurse to court, and the court will seize the nurse license and jail the nurse. And people will be worried that why is the nurse? At least she was doing the best, but you can't go ahead and perform a dependent intervention without the doctor's order. You can't give oxygen without an order to administer oxygen to patient. Yes, the patient was having respiratory distress. You give oxygen, but the oxygen has gone to what? Blow to destroy the hypoxic drive in the brain. Okay, why? Because there was no order for you to give oxygen. When the doctor will prescribe oxygen, the doctor will specify give 2 liters per minute, give 3 liters per minute. You went and gave 6 liters per minute. Meanwhile, the patient was supposed to take 2. So you acted, you went to perform a dependent intervention without what? Yes. And there are some, so the nurse manager, as if you are the nurse manager, or if yes, when we go to work, sometimes, especially weekends, nurse managers will not be there. So the senior most nurse is mostly used as what? The one to manage care, okay, for the day. You can be working with student nurses, new graduates who just passed their licensing exam and got employed. You are the senior most on duty, so you will be the one to manage care within your vicinity or within the ward environment for that shift. Okay, so that is what we are saying. And the independent ones to, positioning a patient does not require what? The doctor's orders before we turn the patient left or right to protect skin integrity. Okay, yes. Turning patient every 2 hours. You are working on the neurological ward. Somebody has a spinal cord injury. We turn them 2 hourly. Okay, yes. Or in the ICU, turn them 2 hourly. You don't need a doctor's orders to do this. Okay, so this one is called independent. You have the freedom to do. Okay, then we have collaborative interventions. It requires cooperation with other healthcare professionals. Okay, so the patient cannot swallow. We are trying to give the patient food, but he or she cannot swallow. Okay, let's go and call the food and nutrition or the dietitian, okay, to come and assess the swallowing ability of this patient. We call it the dysphagia assessment. So after the assessment, the nutritionist will order for what? Okay, let's give thickener. Let's give this. Let's give soft diet or bite-sized food to this patient. So we have collaborated with other health workers. Okay, that is called what? Management of nursing care. So the nurse in charge or the nurse who, when he or she is drawing the care plan, she will make that note in it that patient, the nutritionist was contacted for this patient's diet orders. Okay. And so and so was prescribed for this patient. That's it. Okay. So we do collaborative care. Evaluation is always done by nurses and so forth, so forth. Okay. Let's look at clinical judgment models. clinical judgment. This is where a lot of people feel, especially those who write English, a lot of people feel this area. Recognizing cues, analyzing cues. It is one of the challenging issues with nursing licensing exams. Okay. Or back to the word, it is one of the challenging issues for most nurses, especially new graduate and student nurses. Okay. We call it clinical judgment. Clinical judgment. Okay. Clinical judgment. You are practicing care. You are delivering care. You are dispensing care. You meet several patients, or you can meet one patient. The patient will give you several signs and symptoms. I'm having headache. I'm having chest pains. I'm sweating diaphoresis, like the example we are seeing here. Let's use this one. Example, recognize cue is the first step. Okay. So patient has been complaining of chest pain, diaphoresis. Then you did your labs and you saw what? Elevated troponin. Okay. Okay. So with this, you now say that, okay, this patient, I'm trying to recognize a trend. Okay. I'm trying to recognize a trend. Okay. So let me now what? Analyze this presentation I am getting here and make decision. Okay. So according to the books, according to physiology, according to this, if patient comes with chest pain, diaphoresis, we take blood samples to the lab and it comes back with elevated troponin. The kidney does not have troponin in it. The liver does not have troponin in it. It is the heart that has troponin. So what is, and even in the heart, it is in the muscle that has what? Troponin. Okay. With chest pain, diaphoresis, you did your labs and you got this elevated troponin. So this one has given you a cue. It has given you a cue. Okay. I don't know which word to use, synonym to use for this cue. It has given you a cue that, okay, this one can be malaria, this one can be this one can be this. You have so many diagnosis. Okay. But among the signs and symptoms, there will be a cardinal sign or a cardinal activity that will help you to recognize the cue. That is what doctors use to diagnose patients. Okay. You can't just give medication to patient without collecting the patient. And when you are collecting, you collect your data. That is why the nurse is supposed to do the initial assessment. You can't go and give initial assessment, or you can't go and do all the advice, the assessment. You can't go and give to any LPN or any UAP, healthcare assistant, to do it for you. Okay, yes. So now we've seen this. Let's analyze this cue. After analyzing it, you came to a conclusion that what? This is what? A possible acute myocardial infarction. A possible, see, the word is a possible, a possible, a possible, because you are doing analysis. Analysis. You are analyzing this cue. So you came with a conclusion of this is a possible acute myocardial infarction. You don't end here. A lot of people get it wrong with NCLEX and other stuffs. Okay. Yes. Yes. People are saying just for hint. Cool. So after that, you what? You prioritize your hypothesis. You will prioritize your hypothesis. So you look at the problems the patient has presented, then you prioritize. You determine the most urgent problem. So this one like this, patient has come with chest pain, diaphoresis, elevated troponin. Okay, you look at this problem, then you ask yourself, which one is the most important for me to do? You are prioritizing this hypothesis. When you go down here, another patient also came with anxiety, fatigue, decreased cardiac output. Okay, anxiety, fatigue, decreased cardiac output. So decreased cardiac output can tell you what will give you the clue that, oh, okay, this person is having what? He can be having heart failure. Okay, or he can be having any heart condition or cardiovascular condition. That is why anxiety is there, fatigue is there, is a problem. But let me prioritize the hypothesis. Okay, decreased cardiac. So once you know this, once you prioritize this, then you come out with a plan, a solution. You develop an intervention. That is why we say that this thing, it is the nurse manager who is supposed to do it. Sorry, I did not on my. All this thing is the nurse manager who is supposed to do it. Okay, you develop interventions. So what am I going to do? I have identified this problem as my priority. What interventions can I make around this priority? Okay, I'll give oxygen. I'll give my aspirin. I'll give my cardiac monitoring. Okay, and I'll do my what EKGs, 12 lead EKGs to know what is going on. So after drawing the plan, then you implement. That's where we have independent intervention, dependent intervention, collaborative interventions. Okay, so this one, administering oxygen and obtaining EKG, the nurse cannot out of his or her will prescribe right in the nurse's folder that or they give this no. Okay, so this one, she depends on the doctor to do it. But this patient, sitting the patient up in an upright position does not require the doctor to prescribe or make orders for the nurse to obey. Okay, so a lot of interventions will come with this problem. Then, after everything, you evaluate your outcome, assess for response. So, chest pain has decreased, oxygen saturation improves. That's it. Let's look at another clinical scenario. So, we have this patient came with fever, productive cough, respiratory rate of 30 over 30 count per minute, oxygen saturation 88%. This is the presentation of the patient. Who can tell me a gist, or who can tell me a clue? Can you recognize any cue here? Is your mind telling you something about a diagnosis, a disease pattern? Who can tell me? Yes. Yes. Send your comments to the chat box. Uh-huh. Samsung, you want to talk? Yes, you can unmute yourself and talk.
Pneumonia, sir.
Okay. Samsung is saying, I don't know your name, but pneumonia. Somebody is saying pneumonia. Yes. Any other person?
COPD.
COP. Okay. You see who will be right. Yes. There is a Q. Okay. So let's base on these two people. Samsung said pneumonia. Okay, someone says tuberculosis, TB. Among these signs and symptoms, which one did you base on, Samsung, to say it is pneumonia?
So the fever, productive cough, and then the respiratory rate.
So
The
you
saturation was
capitalize on
4. Yeah, the 3.
okay. So you look at all the three to make your
Mm.
pneumonia. How about the other lady who said COPD, and somebody also said tuberculosis. So you should tell us why you chose tuberculosis and which one was your key clue, your master clue. Yes.
Respiratory rate and oxygen saturation.
Okay, so you are looking at these two to say
Yes.
the COPD, to relate it to COPD. Okay. Then the person who said tuberculosis, yes, acute respiratory distress. The person, yes, tuberculosis is not, if you are, you don't want to talk. Okay, let's look at these two guys. So now we have recognized our cue. Let's analyze the cue. Somebody said pneumonia. Yes. Is there fever in pneumonia? Yes. Okay. Pneumonia patients, do they cough? Yes. Do they have higher respiratory rate? Yes. Okay. Then can their oxygen saturation drop? Yes.
Yes,
So
yes.
pneumonia. Take. Now let's look at COPD. COPD, do they have fever?
No, sir.
Yes or no?
No, no.
No, they don't have. Yes, sir, they don't have.
They don't have. Okay. Do they have
Sir, they
projective
have
cough?
fever, but it's often low-grade fever, sir, because of chronic inflammation.
But so even you use the word low grade, so it can be our master. It's a cue, but we are analyzing. So when you are analyzing it, you look at what the key differentials. You understand? The key differentials. Okay. Yes. So productive cough, COPD. Yes, they said they have. Do they have respiratory rate 30 over? Can they go to that level? COPD. Yes. Yes or no? Sharp, 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 sharp. Let's go. Did they say yes or no? COPD, respiratory rate 30.
So
No.
they don't
They said
have.
no.
Yes,
Okay.
no.
Saturation 88. Everybody knows. Okay. So with our analysis, yes, this one passed for the two, but this one failed for COPD. So you hold on to what? Pneumonia. Somebody will say respiratory distress. Somebody, like so many things. So what condition that came to mind? You should check mark with all the signs and symptoms that you are seeing. Okay. So once you check mark and it goes with them, then you make a plan. That is a solution. You draw a solution to it. Oh, okay. Now I have what? Pneumonia. So let me make a plan for pneumonia for this patient. Okay, give oxygen, do this, antibiotics, IV fluids, whatever, diet, plenty things. Do your plan. Okay, after the plan, you intervene. So the interventions, you ask yourself, which one can I do it by myself? I don't need a doctor's order. Which one do I need a doctor's order to do it? And which one do I need other staff? I need a dietitian. I need respiratory therapist. I need those people who do exercise for us. What's their name? I do. Or physiotherapist. Yes,
Therapy.
yes. So I need all these people. So we call it collaborative intervention. If you look at these three angles, you are done with this condition. Then after the intervention, you come and evaluate the care to know, oh, okay, fever is gone, productive gone is gone, respiratory rate has come back to normal, oxygen saturation has increased. Okay, now let's go down and look at our solution. So with the Qs, they suggested what? Pneumonia with impaired what? Oxygenation. So the person who chose pneumonia got it, and the one who also said respiratory distress. Okay, we can also consider him. So let us prioritize. So among these, what are we prioritizing? They are prioritizing what? Impairs gaseous exchange. So saturation is dropping. If you don't do anything about it, if you don't do anything about it, the patient will crash, he will die. Okay, so what can I do? Oxygen, antibiotics, chest X-ray, and all those stuffs. Okay, then you do your evaluation, and that's it. Okay, so this is what a nurse leader, a nurse manager, I'll not even use the word leader, a manager, because we are doing management. We are not doing leadership in nursing, we are doing management in nursing care. Okay, so the nurse manager should ensure that this thing is done according to the hospital's principle, according to the Nursing and Midwifery Council principles, according to whatever WHO, all these organizations, we follow by it. So you can't go for a nurse manager role, or you on the shift, you can't say we should make you a nurse manager if you don't know the principles and guidelines to all this. Somebody is going to give injection. Okay, I am injection. Then you saw the nurse giving it in the abdomen. Yes, you ask yourself, this medication, according to the principles, should it be given through the abdomen or through the gluteus muscle? Okay, so the nurse manager will intervene. So now let's go and look at what is the difference between manager and a leader, a nurse manager and a leader. Okay. Or the leadership focuses on influencing and motivating. That's their action, that's their verb. Okay. The duty of the leader is always to motivate and influence others. So we go to work in the same work environment, plenty nurses. Okay. The lead, you realize that the leader is always motivating you. Oh, motivating the other colleagues, motivating. Sometimes we make mistakes, and when the manager's position becomes vacant, we will choose the leader to go and apply for it, and everybody will say, yeah, let's give it to her. This person will pick up the position and will be struggling with management, because when somebody goes wrong, because he or she is always motivating and encouraging, they don't have the skills to rebuke people when they go wrong. They don't have the skills when we give you rota to draw or schedule to draw for the month for nurses. Because meeting among nurses, okay, going to patients to talk to them to know if they are receiving the best care, quality control. They don't have it. Okay, he's a leader, he's motivating people on the world. But when it comes to the care among the colleague nurses, among patient relatives, among patients themselves, among other health workers who comes to the ward, this person does not have the skills. Okay, so what do leaders do? They inspire, they encourage team workers. They motivate you. They can even buy food, give you gift, everything, motivate you to work. Okay, but when you give them management, they struggle. Leaders always promote growth. Okay, yes, they will promote. So your colleague will be pushing you. Ali, people are traveling. Let's go to school. Let's go and write this exam. Let's go and do this. They are always motivating you to move ahead in life. But they are more managers. And they improve what? Morale. on the world environment. These are leadership. Okay. So characteristics of a good leader: visionary, good communicator, motivate staff, support growth. So we have a clinical example. A charge nurse motivates staff during a difficult shift and helps solve the conflict. This is what a demonstration of leadership. But how about a manager? The verb we use for managers are they accomplish tasks. One, and they also would help maintain order. Okay, they accomplish tasks, and their differential is to maintain order. You are working within a school. Okay? So the next manager or the one who is managing care will make sure that everybody does the right thing. Not his or her fault. The position he or she is occupying comes with that responsibility. You see some nurses, some health workers having problems with their nurse manager, that this nurse manager is this, that is so strict, is so this, is so that. Okay, let's take the position from them and they become like us. You see them, I mean, moving freely with us, talking nicely with us. That's it. Everybody will behave the same. So people become leaders, nurse managers, the next moment they have resigned because the job is too much for them. They can't take it. So the nurse manager or the one managing care, on weekend, we went to work. The nurse manager is not there. So among the nurses, we will take one to be the leader for the day or the manager for the day. Okay. So the manager will come and share the job. They plan for the shift. Okay. This patient in room 1 needs bathing. So healthcare assistant A, you are going, I will assign you to this one. This one needs one-to-one care. Healthcare assistant B, I will assign you to. This plan needs updating. Nurse, so and so, you are in charge of this. So they will draw the plan for the day and make sure everybody does their own. Okay, so he or she will be going around with his or her paper. I give this person this job. Let me go and see if it was done. Okay, and if it was done well. So sometimes some of them will even go to the patient and talk to the patient that this person did she talk to you well? Did she do this? Did she do that? That's it. They organize, they coordinate, and they evaluate whatever tasks they assign to people. That is management of care. Okay. When you're doing all these things, they still work within what? A scope. Making sure that they don't go outside the scope. So this is within the scope. Within the scope, we have WHO principles. The hospital we are working, we have the hospital policies. Okay. We have the nursing within that state. In US, we do state by state. So we have what? The nursing councils, their principle, their guidelines. The nurse lead manager make sure that all the nurses are working within this scope. So you realize that a nurse is taking care of a patient in the ward. Okay. Yes, she's doing her work 100%. This nurse will be selling what? Pure water, or selling bowls, okay, and selling things to patients. Yes, immediately you start selling things, the nurse manager will now ask, our nurses supposed, according to WHO, our nurses supposed to sell things on the ward? No. According to hospital policies, are nurses supposed to sell things? No. According to Nursing and Midwifery Council, are nurses supposed to know? So it means the nurse is working, but she had practicing something outside the scope. So the nurse manager will intervene that, hey, this thing you are doing is not allowed. So please stop. Then the nurse manager will bring the nurse back to the scope. That is it. Okay. A patient has come to the ward and fighting and causing commotion. Is it allowed per the hospital policy? No. So the manager or the nurse on duty should call the security to come and put the patient in. You work in the ER, they've brought a patient who has taken a lot of alcohol and is causing serious issues on the ward, destroying things, breaking glasses and all those stuff. You call the security to bring the patient to the scope because the hospital policy does not allow that. Okay, that is management. That is management. So characteristics of manager: scheduling, budgeting. They budget. Yes. So those of you who work in care homes, managers will budget a lot for you. They do yearly budget. So at the beginning of the year, let's say the company give them like, let's say 1 million or 1 million pounds or cedis, whatever amount. Out of this 1 million pounds or dollars or whatever, they are supposed to take some to buy food for patients on the ward, on the care home. They are supposed to buy stuff, toiletry and groceries, whatever, to make sure. And out of it, they are supposed to what? Pay staff and do all those stuff. Okay. So yes, some of the companies at the end of the year, if you, the manager, you were able to manage and take, let's say you spent 800, 800,000 and you took back 200,000, that, oh, they'll see you are a good manager. Okay, because of that, take 10%. It's a reward. Okay, so what do some of them do? I'm not exposing anyone. Sometimes we go to work, there is short staff. Managers are supposed to book agencies to come. They will not book. They will say, okay, you can manage. They will call. You can manage, eh? Okay, don't worry, I can manage. Or some of them will call you, they're short staff, they will call some of the staff from home. Because if they take agency will take them double pay. So they'll call the staff, please, can you come and help us? We are short staff. We will give you $5 per hour as motivation. Then they come and when you are happy, you come in and work. Okay, it's a plus for the manager. That's it. So the manager budgets and also ensures that there's staffing. A manager is not supposed to close and go home without knowing the number of staff who are coming for the next shift. Okay. Sometimes we go to work. It is when we go to work that we realize that this person, there was a mistake on the roster or the schedule. Instead of every day 5 nurses, not knowing it was only 3 nurses and nobody saw it. Whom should we blame? The manager. Okay. If the facility does not have a manager, the nurses who were running the shift, the previous shift, what were they watching that they did not see this? Who is the manager among them? So that's it. And they should always ensure what policies are implemented. Perfect. So a typical example is what? I'm running very fast. Assigning patient and creating staff schedules demonstrate what? Management. That is it. Manager can delegate that, oh, you, the nurse, you are in charge. The manager too is also sometimes a nurse, but when you go to care home, they can choose somebody who has done business management and make him or her a manager. Okay. But when it comes to hospital settings, on the nursing ward, the manager is always a nurse. So the nurse can also schedule that. The nurse manager can reassign that, oh, so and so, you have given you the duty of what? Drawing rota. Okay. Then the night nurses too will give you the duty. Okay, you draw your own rota, you to draw your own rota. Perfect. At the end of the day, she will ensure everybody does, and there's peace on the ward. That's it. That's the manager. So this is the comparison table. You should get the slide and you go through. It talks about everything we have said. So the leader will inspire. The leader is vision oriented. But the manager is task oriented. Encourages changes. This one maintains stability and focuses on people. Sometimes some leaders will be motivating their colleague nurses. That, oh, see, I have seen that flight nurses, they are paying them, oh, let's resign and go. Then they will resign and go. Okay, but the manager will never tell you to resign and go and work somewhere. Okay, so you yourself, you are listening to me, you know yourself, so your colleagues, it can be you or it can be any of you. Some of your colleagues will come to you, they will come and motivate you to do certain things. They are leaders, they are motivated, they are encouraging you. Okay, but they are not maintaining stability sometimes. Because the manager will always maintain stability, enough staff, enough budget, enough logistics, everything. That's it. So these are the leadership styles we have. Those leaders who are always motivating us, how do they motivate us? Some of them will use autocratic ways, okay, authoritarian ways. Yes. Some of them will use democratic way. Staff, I'm just skipping because we know this already. Staff participate in decision making. Yes, I don't want to make decisions for you alone. You to bring your mind. Let's reason together. Some will be fair, minimal supervision, encourages independence on the word. Free Ubuntu, everybody does whatever they like. Poor coordination, that's their disadvantage with laissez-faire. Okay. Transformational leaders, they are the best. They promote growth and innovation. Innovation. Okay. So among the nurses, encourage them. I always tell my admins that if you are a leader in your absence, the group does not continue or the program does not continue. It means you did not build well. Some of the leaders we have, they can't even go on leave or pension. Okay, because they've not trained anybody to take care of the system when they are not around. Okay, so the manager mentors what? He ensures proper mentoring, inspiring people, team building. Okay, so that people will be what? No, the system will always run because you can't do all. The leader will inspire, the managers will organize. That is it. Assessment comes before intervention. Evaluation determines if goals are achieved or not. Okay. And your ABCs, this is the physiological things. Airway, breathing, and circulation is very important. Okay. Now, let's look at this question. What action demonstrates management rather than leadership? Choose your answer before we move to the next one, before we go to prioritization. Yes. Which nursing action? When you see action in nursing exams, it means nursing action. Which nursing action demonstrates
C,
management?
assign patient care responsibility.
Explain. Somebody is choosing this one. Why? Why will you choose C?
The reason is the leadership in that field focus on patient responsibility. I mean, patient care.
Okay. She says the leadership focuses on patient care. The question is, which action demonstrate management instead of or rather than leadership? But you're talking about leader. Can you reframe your rationale? Yes.
What I'm actually saying is the management focus on the responsibility of each individual staff by assigning patient care responsibility to them. I don't know how to explain further than this. But a leader will rather like look into teamwork, look into mentorship, how you are going to do things right, if you are doing something right. But if you are trying to like manage a situation, you want to see that, okay, that care you are giving to you, you are taking responsibility of it. That is the way I understand it.
So the manager does what the leader does. Okay. But the difference is that the manager will make sure that everything is done according to the policies, according to the principles, according to this. So if you look at these options, encouraging teamwork among staff. Yes, managers also encourage us.
Yeah.
Okay. Samsung. Do you want to say something? So managers also encourage, but leaders, when they encourage us, it ends there. The leader doesn't care whether whatever you are doing is within the scope or not. A leader can come and motivate you, encourage you that let us go and do locum when we close from work. Okay. And yes, they are always looking for what will motivate people to grow. Okay, the work we are doing. Let us do this, let us do that. They met new graduates. Yes, they teach you. A leader on the world will teach you the work. Okay. But he or she doesn't care whether you are following the principles of the hospital or the principles of NMC. Okay. But the manager will teach you and make sure that you do the right thing within the scope of practice. That is it. So ask yourself, are you a leader or are you a manager? Okay, that is it. Some of our nurses are managers. They will question you, even their own colleagues, they will question, you did not do this right. Then we always find trouble with them. Okay, yes. So the answer is what? See, I will leave it unanswered so that when you get here, you try yourself again. Okay. Right. Let's go to model 2. They are doing 5 models. One is gone. So all the NCLES framework, whatever, is gone. Let's go to prioritization. The manager, the nurse as a manager of care should know how to prioritize. Okay. We are giving patients A, B, C, D to one nurse. Let's just test especially those who write NCLES. They will now ask you, let us test this nurse. Is she a manager or not? So we will give you 5 different patients or 4 different patients with different conditions. Then we test whether the man, because what did we not mention the leader here? We are not testing your leadership skills here. We are testing your managers or management skill here to know whether you will be able to prioritize, you fish out. The one we should use the resources, the little resources, because the manager, they are very efficient. The resources are less, they are scarce. Okay. We have only one oxygen cylinder, but we have 5 different patients who need oxygen. Which of them should we give this oxygen to? The nurse manager should have that ability and skill to manage and bring out the patient that we should give. That is what. So anytime you see prioritization question, you are testing what? Your management skill. You are managing care. Okay. So I have used this acronym, AMASA, the right invention. So you can't manage care without knowing the bundles, the bundle of prioritization in nursing. Okay, open your eyes and open your ears. What this thing I'm telling you now is going to help you. If you catch this, you are done with prioritization. Okay, the bundles. We have bundle A, that is the ABCD bundle. That talks about airway, breathing, circulation. Bundle B, that talks about Maslow's hierarchy. Bundle C, that talks about acute or chronic conditions. Bundle D, that talks about stable versus unstable patients. And bundle E, that talks about actual versus potential problems. Sometimes they can give you different patients, but they will focus, if they want to be lenient with you, if they want to be the computer or whatever, if English you are writing or whatever, CBT and OE, whatever, if it wants to be lenient on you, it will choose only one bundle and give you this that prioritize as a nurse manager and use the little resource to manage that patient. Sometimes too, they can take all these bundles. So they will give you a patient with what? ABCD problem. They will give you a patient with Maslow's hierarchy of needs problem. They will give you a patient with acute and chronic problem. They will give you a patient with stable versus unstable problem. And they will give you a patient with acute, actual, or potential problem. 5 problems, 5 different patients, and they tell you to prioritize. So the question, that prioritization question you got, ask yourself, where does it fall under these guys? Prioritization, this is it. They can never give you a prioritization question outside these 5 things. So if you want to remember these 5 bundles, their acronym is what? AMASA. So the ABCD, the Maslow's, acute, is the patient acute or a chronic patient? Is the patient stable or unstable? Is the patient having the problem, the headache that the patient is complaining, is it an actual problem or a potential problem? This is what you use to check mark. Okay, this is what you use to check mark. And after you are done with it, we will do examples below. You will see how to apply it. When you finish this, your answer will be blinking. And you will smile that, Jesus, this thing I've been struggling. Okay, so prioritization is one of the most heavily tested components in nursing curriculum. When multiple patients need attention, the nurse must determine who should be seen first using several priority framework. So this is bundle of framework. Don't forget Amasa. So let's take it one by one. The framework or the bundles. Let's take the bundle of ABC. Notes that when I get patient A, B, C, or D, whatever, I will always tackle airway first before breathing, before circulation. Okay, the framework. So airway, you ask yourself, is the airway open? Airway, if this is airway, the airway starts from the mouth to the last bottom. Okay, the alveoli. This is it. Forget whatever the name, whether it's trachea, whether it's this, what, forget about it. The potency of this way, oxygen has been breathed in, it is going down. Nothing is stopping it on the way to here. Carbon dioxide is coming out, nothing is stopping it. That is what we call airway patency. Okay. So when something block it, is it an aspiration? Is it a stridor, as in upper airways, or wheezing, lower airways? Is it choking, especially in children? Is it tongue obstruction in unconscious patients that you've put the head down? Tongue will roll back and obstruct what? The pharynx, the oropharynx. Air cannot go. And the nasopharynx cannot go. Okay. The truth. Whatever swells outside, the inside also swells. So it closes the airway. Or is it a foreign body aspiration? Okay. This is what you should know. So typical examples, we see it in epiglottitis, anaphylactic shock, or anaphylaxis, okay, laryngeal edemas. This is the highest priority. The airway must be opened. Okay. Before you come to breathing. Breathing, yes. Now, the oxygen, see, this is, let me draw the airway again. Breathing. The simplicity of breathing is that, okay, oxygen was outside here in the atmosphere, ATM, let me use it. We want oxygen to go here, and carbon dioxide is here. You want carbon dioxide to come out. How can we do that? We need muscles. We need a lung. We need bones. We need diaphragm. They are all muscles, okay? We need nerves. The nerve, the phrenic nerve, and all those. We need all these components to come together to open the airway and to close it. To open and close. Open and close so that oxygen will go, carbon dioxide will come, oxygen will go, carbon dioxide will come. That's it. So if patient, all these things I have said, somebody takes a scissors or somebody cuts the phrenic nerve, the nerve, breathing is in trouble. When somebody punctures the lung, breathing is in trouble. When I break or anybody breaks, car accident, your bones, okay, the intercostal bones or whatever, the bones, when it breaks, breathing is in trouble. When the muscles in between these bones, we call it the intercostal muscles, some of them tears, there will be pain, breathing is in trouble. When from is hijacked that it cannot work, okay, it is hijacked, breathing will be in trouble. Okay, is airway a priority over breathing? Yes, let's assume that the diaphragm is hijacked and I cannot breathe. I can still put a machine on the mouth or the nose of this patient and push oxygen to the cells and bring carbon dioxide. That is it. So when I put a machine here and I'm able to achieve ventilation, I don't think that whatever the diaphragm will do, you should do. I don't care. Okay, that is why it is always, but all these ones comes together to form a bundle. Okay, Yes, the ABCD bundle. So you see all these conditions: shortness of breath, tachypnea, wheezing, cyanosis, oxygen sat below 90. Conditions like asthma, pulmonary embolism, tension pneumothorax, or simple pneumothorax. This is a second priority. Okay, now let's go to what? Circulation. Circulation is all about what? The heart and the blood vessels. So the arteries will take it away wherever it is taken to. Then the veins will bring it back. This is all about circulation. If something happens to the heart, circulation is in trouble. If it happens to the blood vessels or in the blood inside, becomes so thick that it cannot move and start clotting, circulation is in trouble. Okay, so patient will come with plenty problems, and we have medical conditions over here. Okay, this will become what? A third priority. Okay, so let's go down. And for patients are admitted to the unit, one is having what? Anxiety. And let me tell you this word. When you see weight, this word weight, it means the person, that problem that follows after weight is currently happening. Okay, yes. Patient with anxiety, patient with chest pain, patient with stridor after thyroidectomy, and patient requesting pain medication. They have given you these 4 patients. Which one should you see first? Okay, so this question, it is being lenient with you. Okay, yes, because if you apply the ABCD bundle, you realize that what this stridor tells you about airway obstruction, and the obstruction is in the upper airway. Okay, yes, this is an emergency because airway should be prioritized. Okay, and all these things, circulation issues, patient requesting pain and all those things, they are just teasers to worry you. They will give you the cue. Recognize it. Recognize the cue. Okay. So stridor indicates airway obstruction, which is immediately life-threatening. Okay. Another example. Tell me the answer. Which one will you choose first? You are a nurse manager. You are managing care. Which patient? Using the ABCD bundle.
I'll choose A.
Authorization. You choose what?
A.
B.
Somebody said you choose B. Okay. Why? ABCD. ABC bundle. Yes.
Because immediate post-op. Okay, they didn't state in the question though, but I am assuming that it's immediate post-op without a numerical value of 8 on 10. So you need to manage the pain. You can't leave the patient to be in pain for long, else it will alter the vital signs.
She's saying immediate. She has used the word immediate. It's immediate in the question. You are thinking for the question. Never do that in any nursing exam. Don't think for the question. Once you think for them, you choose your answer wrong. Okay. You can be right, but never think. COPD patient with saturation 89. Post-op patient with pain 8/10. Patient awaiting discharge and patient requesting sleeping pill. Which of them will you choose?
B.
B, sir. B.
B.
Yes.
So like I said, you can be right, but never think for the question.
Okay.
Don't
Thank you.
introduce any words that are not there.
Okay.
So I'll leave this one. When you get the slide, you try yourself again. I will not answer it. I will not highlight it. Okay. So airway will always beat what? Breathing beats circulation beats, yes. When it comes to using the ABCD bundle to answer the question. Okay. Now let's continue. The next framework or bundle that we are going to use is what the Maslow's hierarchy of needs. So you prioritize Maslow. Listen to this one. It helps prioritize when ABCD are not obvious. I'll highlight this for you. Okay. When ABCD, so look at the needs. We have the physiological safety, life and belongingness, esteem needs, self-actualization. Physiological needs, the needs that will make us survive. It is a continuation of the ABCD. Okay. The ABCD is also a physiological need, but it comes before this first physiological needs. Okay, so the food, water, breathing, whatever, safety, shelter, health, property, future, and all these things, it goes in that upward format. So when you pick the physiological need, if you want to use only, and they can give you a question that they will give you 1, 2, 3, 4, 5 patients. One is having safety need, love and belonging need, esteem need, self-actualization need, physiological need. Okay, you now ask yourself, so always, what is my acronym? What is the acronym? When you get the acronym, AMASA. When you get the acronym, then you analyze yourself. This is AMASA. Okay. Can I see any ABCD need here in the question? Can I see any Maslow's hierarchy of needs here? Can I see any acute or chronic? Can I see any stable or unstable? And can I see any actual or potential complication? Yeah. So you did your first check. The question said that if ABCD is not obvious, use what? The Maslow to prioritize. So Maslow second. Then you ask yourself, when you go down, you should know all these things. When you go down and you see that, okay, this is a Maslow hierarchy of needs question. So in Maslow's, which one comes first? Physiological. These questions are just automatic. I mean, you don't have to think so much. Okay, there are so many. When we get to questions, I'll show you how to fish out, fish it out, fish it out, fish it out, fish out. Okay, yes. Then you use the what? Maslow. If the question is about the ABCD, you know your ABA will come before B and C. That's it. Okay. So it goes like that. The physiological needs, these are it. So sometimes the question will not write oxygen, or patient needs food, or patient needs this. Okay. They will tell you patient needs food. Okay, patient is what? Hypoglycemic. They have thrown your mind away. They will frame the question that you will not even think about, we are talking about patient needs. So, hypoglycemic patient needs what? He needs what? Glucose to survive. You will not prioritize glucose over ABCD. Person is having respiratory distress. You will not prioritize this over airway patency. Because respiratory distress is a bundle, it's a chunk of conditions that comes together. Okay, there can be water in the lungs, the airway is blocked, the lungs or the organs, some of them is injured or diseased. There can be a pulmonary system, there can be a clot. Okay, so you can. This is a generalized what? I would say a syndrome. Okay, bleeding. Yes, the cardiovascular system. It is circle like this. There is a puncture here, and you are bleeding. Okay. Yes, we need to close this gap so that the bleeding stop. Okay. So it goes like that, and fever and all those stuffs. So that is what you should know. When they give you their basic need, physiological needs under Maslow, you treat it over safety. Safety. A patient is bleeding. This is the heart. This is the cardiovascular system. There is a puncture here, and you are bleeding into the abdomen. Okay. Another patient is here who is in bed, who is having seizures. False precaution. Side rails up. Will you prioritize this over this? Okay. So false infection, physical protection, and all these ones will come next. Okay. So your side rails, isolation, precautions, and all these, they are hot. Safety needs. Love and belonging as a patient who is on the ward crying that nobody has visited her. You can't prioritize her over somebody who needs what? A false precaution. Yes. So because they are having what? Love and belongingness need problems. Self-esteem, confidence, body image. Teenagers, they will come to the hospital. They have done appendix for them. They are worried that their skin is there is a suture on the skin. They are going to get sky. They are worried. They are anxious. You are going to prioritize that over a patient who is having airway blockade. No, it doesn't work like that. Okay. Patient is upset because he's receiving chemotherapy and is getting alopecia. The hair is getting lost. All these things comes in. Then self-actualization. There is an old man on the ward who did not live a good life or even lived good life, help people. Now he is old. Everybody has run away and left him. Okay. He could not achieve his goals in life. Self-actualized. Patient, this old man wants to return to school, or this child wants to return to school, because the fact that he did not go to school and has been admitted on the ward means he is a failure. His classmates are learning and he is nobody is teaching him in school. They are writing examination and only him in hospital. This is a self-actualization problem. You can't give this patient attention over an asthmatic who has been brought to the ER and having status asthmaticus. It won't work. Okay. So example, which patient should you see first? So sometimes they will bring you a Maslow's bundle to answer. And your attention will not come there. Okay. So the first patient is patient anxious about surgery tomorrow. Where does this fall under?
That's psychosocial.
Psychological.
This is psychological. Okay. So if this is psychological, where will you put this? You see how they frame the question? Where will you put this here?
No.
Because you should be able to link it.
Physiologic. Oh, no. So, oh, no.
Speaking of esteem, esteem is too far.
Yes.
Physiological, because anxiety will
It's
also
what?
alter the normal functioning of the body.
Love and belonging.
Love and belonging. I've changed my
I'm
mind.
thinking about safety and security.
Safety and security.
Okay. Safety. He's worried. Fear of the unknown. Patient safety. Safety. He's worried. Okay. He thinks something might happen to me if I go. Where is it? Where did we even get to? Where's the question? Yeah. Something might happen to me. What if I go and I don't come back again? He's worried about his safety. You see how you put the questions? If you don't learn, if you don't catch this thing, you always be worried. Okay. Let's look at this one. Patient who has not voided in 12 hours.
Physiological.
This is a physiological need. Okay. That one there, physiological need, if you see it, you see it. Okay. Yes. Patient worried about losing hair.
Esteem.
Self-esteem.
Self-esteem.
Yes. Are worried about their body image. Okay. Then upset because family hasn't visited.
Love.
Where will
Love.
That is love.
Love.
Love and belonging.
Okay, so if I tell you to rate, how will you rate it? This one will be number 1.
B. Yes.
Which one will be number 2?
A.
A. Because it's a safety problem. Which one will be number 3?
D.
D.
Okay. Yes, love and belongingness. And which one will be number 4? Definitely C. Okay. So, as a nurse manager, the resources you have on your ward is less. So the little resource you have, you give it to this person to stabilize this person. That is what we call management of nursing care. Subtopic prioritization. That's it. Okay. So we have done recognizing cues. So you know how to recognize your cues and prioritize hypothesis to draw a plan, then you continue from there. Now prioritization 2, we have gotten to Maslow. Okay. So physiological needs always comes before psychological needs. Okay. Let's leave Maslow. Let's go to the next one. Amasa. The Amasa, the third A. The Amasa, yeah. Patient who is coming with what? Either an acute problem or is having a chronic problem. This one we have seen it over and over and over and over and over. Yes. Acute over chronic, acute over chronic, acute over chronic, acute over chronic. 2 patients are lying on the ward. Once conditions suddenly changed, okay, or a new onset of so and so, okay, this is what we call acute. There's a framework. They can give you questions, different patients under this bundle, and tell you to prioritize because you are a nurse manager. So acute conditions are sudden and often life-threatening, and chronic conditions develop slowly and are long-lasting. Okay, so let's look at some examples. So we have acute condition MI, pulmonary embolism, stroke, sepsis, hypoglycemia. The last time we played our match, they said one young lady, he's a lawyer, he had a heart attack and died out of, yes, because when Ghana scored, she was so happy that she got a heart attack and died. The question is, the people around her at that moment, did they know this thing, this topic? Did they know this topic we are dealing with now? You see how unsafe we are in the society we live. Because if something happens to you now, you would rather be pouring water on you instead of doing CPR. The heart has stopped working. Somebody has collapsed suddenly. What can we do to maintain physiology? Okay. We are pouring water on the patient to make the system cold, forgetting that physiology needs temperature 36.2, 37.2 to work. You're reducing temperature. How do you ensure physiology and metabolism? Oh, God. So stroke, sepsis, hypoglycemia, yes, is a priority. Acute conditions is a priority. That is why when patient comes to the emergency unit with a stroke alert, with a sepsis alert, everybody stops whatever they are doing to what? Take care of the patient. Somebody comes with what? Hypoglycemia. Everybody stops what they are doing and they tackle the patient. Okay. Chronic conditions, diabetes, hypertension, arthritis, COPD, all this, they are lower priority. Don't give attention that much to it. Don't waste your resources on it. Okay. A patient with chronic back pain and a patient with new onset of chest pain, we will definitely give the answer to B, because chest pain represents acute condition, especially new onset as the qualifier. Okay, let's look at this example too. Tell me your answer. A stable diabetic with blood glucose of 130. If you want to know the millimoles, divide by 18. And a diabetic with two diabetic patients. The second one is a diabetic with blood glucose 40 and confused or having confusion.
B.
Yes. You go for what?
B.
Because we are looking at what? Stability, acute over what? Over chronic. Yes. So 130, some people will not even give any glucose, the insulin. Okay, this is a stable patient. So acute changes always take priority over chronic. Now let's look at stable over unstable. Let me ask this question. How will you know that a patient is not stable? Can you give me an example? Okay, let me make it simple. How will you know that a patient is having unstable cardiovascular system? Yes. Because you need to use the systems to determine stability. If you don't know your body systems and the assessment of the body systems, it will be difficult to know stability or instability in human beings. So somebody has come with an unstable cardiovascular system. Somebody should shoot. Yes, Samsung. How will you know that this patient has unstable cardiovascular system? Yes. Somebody said confusion. Jesus Christ. Unstable cardiovascular system. Somebody is mentioning confusion. You see where our issue is? Yes.
The observation will make it
the patient may be in shock, hypotension. Patient may have hypotension, may have tachycardia, or maybe bradycardia, syncope, fainting attack.
Dysrhythmia.
For me, I feel the observation. I mean, the blood pressure, pulse, temperature will give you a clue or if a patient is stable or not.
Yes.
Heart rate and all that.
Prothrombin levels would differ.
Yes, good. So if you don't know how to assess that system, it will be difficult to know if there are changes. So either it goes high or it goes low instability. Okay. So stable patients have predictable outcomes. But unstable patients have rapidly changing conditions and require immediate intervention. So let's go and look at answers. So characteristics, vital signs, expected findings, and improving conditions. That is for stability patients. Then example, somebody is scheduled for discharge tomorrow because vital signs are stable. A patient on the med-surg unit. Okay, let's come to what? You are working on a normal medical surgical unit. Okay. Then patient's blood pressure starts shooting up. Okay. Patient's blood pressure starts shooting up. It starts giving you 200 over 150. You have used every monitor. You are getting around this figure. You have given patients all these blood pressure medications, dialyzing, whatever, it is not coming down. What next will you do? You need to intervene. So what type of intervention are you going to rely on? And where would the patient be taken to? Somebody should answer these two questions for me. Because you have to be a sharpness. You recognize cues, intervene. What type of intervention are we looking at? Blood pressure is not coming down.
I see you.
Yes,
I
see you.
Put the patient on monitor.
I see you. Place the patient on monitor, do ECG, and then do blood test, full blood test.
Okay. So under independent intervention, you say you put patient on monitor, you do so and so. Okay, cool. Dependent, you call the doctor, okay, and the doctor will make some orders, which transferring to ICU is also part. Getting blood samples, everything. Okay, yeah. So that is how you should do. If you do it, or telemetry unit, perfect. Telemetry unit. Okay. But this telemetry units. Let me tell you something about telemetry unit. Telemetry units looks after what stable patients. Patient has come with a pacemaker. Patient has come with all these stable condition, chronic conditions, but we want to monitor them. Okay, we keep them to telemetry. But when their dynamics, okay, changes, blood pressure is shooting up, it's not dropping down. Let's take the patient to ICU and put the patient on nicardipine drip. Okay. Or all these metropolis and all those stuffs. Yes, we put them on ICU drips to bring the blood pressure down. When the patient stabilizes in ICU, okay, let's give it another 24 hours to monitor. Drip, we have off the drip. Another 24 hours. Blood pressure is still normal. Okay, let us downgrade or transfer to PCU or back to MedSurg or telemetry unit. Simple. Yeah, done. That is it. Nursing is so cheap. So, so unstable, yes. Unstable patients, abnormal vital signs, sudden changes requires immediate attention, like shock, respiratory distress, altered level of oxygen, active bleeding. So example, a post-op 3 days after surgery, and patient with blood pressure 78/42 with heart rate 130. Everybody will go for B because of the instability in B. Okay. Answer this. A patient with chronic atrial fib and a patient with new onset atrial fibrillation. Everybody will go for what?
New onsets. B.
So you don't have to worry yourself that much. Okay. Then high risk unstable patients. If a patient is unstable, this is where we are now going to whatever we are learning today. A patient is unstable. At the same time, he's having an acute problem. At the same time, the problem he is having falls under the ABCD bundle. Okay. Yes. Example, stridor, choking, saturation is dropping, respiration, circulation issues. Okay. You know that this one, I need to prioritize it. So sometimes when they are setting up the questions, they will mix them and give it to you. So you have to sit down and use the amasa. Use the amasa to do your sorting. That this one will go here, this one will go here. This option, answer A, has instability, has acute. It also falls under ABC. And option B has instability, has acute, but it falls under Maslow's hierarchy of needs. You will definitely go for option A. Because sometimes they mix them and give it to you. That's when they want to test, especially you are getting it, you are getting the answer correct. You know, the more, those of you who are doing English, the more you are getting it right, they are making it hard for you. Hard questions. Okay, yeah. So that is it. Neurological.
Hello,
Yes.
So the one that you just spoke about, it just got me confused right now. The neurological, considering the confusion, the decreased consciousness, and then stroke symptoms, and then please can you scroll down a bit for me, sir? And then the saturation 90% and respiratory distress. if I'm to prioritize, say, isn't aren't we going for the neurological, the confusing, decreased consciousness and so,
So this one is giving you high risk unstable findings that you should watch out for. Remember, we are under the topic stability over unstable.
yes, please.
You understand?
Listen.
Hello?
Hello, sir. Please, I'm there. I'm here.
So these are examples of some of the unstable. When we started, I told you that how will you be able to know that this person has unstable cardiovascular system? Okay. And people mention so many, which is here. So hypertension, tachycardia, active bleeding. It means the patient is unstable. Okay. It's example. Somebody always gets hypertension. Yes, this patient is unstable. We will put the patient on telemetry. Okay. But we will also get another patient with hypotension who has a new onset of what? Respiratory or the desaturation. Yes, these two patients are patients whose blood pressures are always low. We have human beings like that. Their blood pressures are always low. It does not make them, yes, to them, they are not showing any physiological symptoms for you to know that, yes. But these two patients, you are managing them on the ward. Suddenly, one started desaturating. This desaturation has become a new onset. A new onset. Okay. So if you use the amasa, if you use the amasa, where is this guy, these two guys are having what? ABCD problem because of the hypotension, circulation. Michael, do you understand? These two guys, let's look at the acute over chronic. These two guys have chronic hypotension, but this guy, the second guy, has developed a new onset, an acute desaturation. Are you following, Michael?
Yes.
Yes. Okay. So, and let's look at the stability. Are both of them stable? Okay. We will say both of them are unstable because of the hypotension and whatever problems they are having. If I want to prioritize as a nurse manager, whom should I prioritize for? If after I did my check marks for this Amasa, I realized that yes, all of them passed, was checked for ABC. All of them was checked for instability. But only this guy was checked for this acute new onset. So it makes me give the nod to him that no, I'll prioritize this guy over this. Mike, do you understand?
Please, yes, sir, I'm following.
Are you sure?
Please, yes.
Not a rush. Me, I can take 1 month to teach this. I don't care. Because I've told myself that I don't want to teach people again for examination. No. I want to teach people because I want people to become good health workers. Yes. So it's a 24 bundle model. Yes. Give me 2 seconds. I'm coming.
Okay, sir.
Do you understand? Forget the acronym I've created for you. This thing, never forget it. If you can use it for triaging, you can use it for triaging. When you get to triaging, you know you can use it because management of nursing care, if you especially prioritization, if you don't know how to apply the AMASA, you are in trouble. You can sit down, somebody can sit down and give us options now. Then we do the check marks. So you should check, okay? Check it, and you are gone. Okay. Yes. So somebody is having neurological problems or confusion, decreased consciousness, and stroke symptoms. This makes this patient unstable. But in the question, is it a new onset or not? These signs and symptoms here confirms instability. Okay. But there is no sentence here that said that the patient has suddenly developed confusion for me to check mark that this patient has what is having a new onset. Yes, the patient is unstable per the vital signs I'm seeing, but it does not check mark me for what? For acute or chronic. So I can't use my mind to think for the question. That is where people get it wrong. So don't forget the AMASA. Who's in AMASA? Okay. Michael, are you there? And the last part of the AMASA is the actual or potential problems. Already occurring. They are the actual problems. Mostly comes with what? Weight. Yes. This patient is having what? Confusion, decrease, whatever, stroke. Yes. Example, or other examples, bleeding. So the question will mostly come, patient so and so weight this symptom that should tell you that okay, it is already occurring. Sometimes they use English to confuse people, the INGs, the continuous verb and the verb. These are verbs. They use it to what? To confuse people. That should tell you that okay, this problem we are talking about, it is already occurring with the patient. So actually, he has the problem. Okay. Then the potential. I have headache. The fact that I have headache, the nurse can anticipate that, okay, if you don't treat the headache, it can give the patient what? Arrhythmias. I have not seen any sign of arrhythmia, but I am just thinking because yesterday a patient came with headache and he became arrhythmic. So today, if I'm seeing another headache, then there is a potentiality that there can be arrhythmias. Let's go and read the examples. So, potential, it may occur later or anticipated. So there is a risk of falls, risk of infection, bleeding, whatever. Example, a patient with active GI bleeding and a patient at risk for, okay, I forgot this one. Let me show you. Anytime you see potential problems, for them, they can't lie. They always use this word, at risk for. At risk for. This one, the one I've highlighted. That should tell you they have used English to confuse you. It means Patient is at risk for. Patient is at risk for. It is a potential problem. So you can prioritize that over an acute or an actual problem. It is English. They will use it to confuse you. Don't worry. This is it. They can't lie. If you like, go to your Q banks, go to your question, whatever. Go and read. Potential problems, always they add this English. At risk for, at risk for, at risk for, at risk for. Okay, that English, or some, if they want to give you a synonym, it will still explain the at risk for. So a patient with active bleeding with, the patient is currently bleeding with, patient with COPD, patient with so and so, patient with hypertension, patient with say, it means they have the problem is with them. And patient at risk for stroke. He hasn't gotten the stroke yet. Okay, so you always prioritize at risk over what? Prioritize active bleeding over priority at risk for bleeding. I mean, yes. So do this. Patient with pneumonia and SpO2. Patient at risk for aspiration. Then sometimes if they want to confuse you, they will add chronological age. A patient 8 years old is a child. A patient with pneumonia, a patient 56 years old. Which one will you prioritize? They add certain things to confuse you. The basics will always be the basic. You can't lie. Because you meet it physically. The patient will come to you. You are the triage nurse. Whilst you are taking care of a patient, ambulance will bring another patient. So how will you manage these two patients? Yes. Yes. So you see, so somebody will choose the B because he saw the 8 years old. It's a child. So child, you need to prioritize children over adults. You saw the child. What was the problem the child was carrying? The problem the child was carrying, does it fall under ABC? Does it make the child, does it fall under Maslow? Does it fall under acute or chronic? Does it fall under stable or instability? Or does it fall under actual or potential problem? Amasa, you are done. If you understand this, we will close the class. Go and solve your questions. You come back with 100%. That's key. Yeah. So read actual problems before potential problems. Putting all together, this is the priority order. Airway, ABC will come first, no matter what, on the scale of priority. Then aqua, unstable, acute problems, unstable, actual. So if you take the AMASA, ABC, okay, and it goes like that. So please take note. Always chronic stable patients is the last. They are the last on the scale. So that one, when you see that those answer options, see, don't even waste your time for it. Concentrate on the other answers. Chronic stable patients are always the last on the scale. Okay, yes. So the nurse received report on 4 patients. Which one should the nurse see first? A patient with chronic COPD, they have the problem. Okay, so this is an actual problem. Chronic COPD, requesting pain meds. Okay, requesting pain meds. Which of the bundle will you put this patient under? Yes. Can somebody analyze?
Chronic unstable.
Okay, so you say chronic. Did you say unstable?
A chronic stable COPD.
So chronic patient. Okay, so always use their master. Don't forget, otherwise you'll be confused. Is this patient having ABCD problem? Yes, COPD.
No. Yes. Sorry.
COPD. Okay, it's happening. Is this patient having Maslow's need? Yes or no?
No.
No. Okay. Is this patient having an acute or chronic condition? Chronic.
Chronic condition.
Okay. Yes. Okay. Is this patient having is the patient stable or unstable?
Stable.
Is that your background? Yes. Is the patient stable or unstable?
Stable.
Stable.
Stable. Okay. Is this patient having an actual problem or potential problem? I did not see
Actual
any at risk.
problem.
So it's an actual
Actual
problem.
problem.
Yes. So yes, let's look at his problems. His problem is our concern. So he has ABCD problem. He has actual problem. This one is acute. He has chronic condition. So it's not our concern. The chronic condition is not worrying the patient currently. So it's not our concern. So he has A and A. Okay. Right. Look at the second patient. A patient who is anxious about surgery tomorrow. This guy is having what? Maslow. Okay, good. See, a post-thyroidectomy patient with stridor.
ABC.
A post-thyroidectomy. ABC.
ABC.
Okay. Thyroidectomy, airway problem. Okay. So yes, he has ABC. And a patient at risk for falls.
Actual potential.
At risk.
Potential.
Potential
Actual
problem.
Okay. So automatically this will be out. This will be out. And you go for your C. Push stridor. We call with. They use the word with. Okay. When you get the slide in this particular prioritization, go over it again. If you don't understand, message me or any other admins. We will get time for you. Okay. Yes. Because it's the major problem for most people. Okay. So this patient is having an airway problem. He has an acute problem. No, it's a chronic problem. He's unstable, actual problem. Therefore, the patient has the highest priority. Okay. If you get more questions, then you bring it up. The golden rule for prioritization, I've explained to you, ABCD, Maslow, acute, unstable, and actual. So always, yes, I'll give you the slide, okay? Then you go by it, okay? These 5 principles form the foundations of nearly every nursing prioritization question. If you don't know these 5 principles, or 6 principles, you'll be in trouble. Okay. Now, delegation. Everybody knows delegation. We are done with prioritization. The nurse as a manager of care, it has come to a point that she has to delegate. How should the nurse delegate? Plenty patient, plenty task. Which one goes to the nurse? Which one goes to LPN? Which one goes to So let me show you the quick formulas, but then we leave here and go. Okay. Right. Tomorrow we continue. So we know delegation is one of the topics that we test. Okay. Before you delegate, ask yourself, what are the activities and responsibilities? That's number one. Two, is it legally permitted for me to what? Legally. The word is legally permitted to give to this person. Person and based on their education, training, or license. Okay. Based on the education, training, or license. So the nurse always does the work, all the work on the ward is for the nurse. That's the trick I'm showing you. I'm opening your eyes. All the work on the ward is for the nurse. Okay? No matter what happens, the nurse must give account to everybody's work. So if you are delegating, the nurse is supposed to bath patient, clean their teeth, wear them clothes, but the nurse cannot do all. So let us give the nurse helpers. So we brought Michael helpers. We gave Michael LPN. We gave Michael healthcare assistant or assistive provider. Okay, we gave Michael. Now, Michael has to ask this LPN, what is his background? What is the level of education? This work I want to give to this LPN, is it allowed for the LPN to do or not? Okay. So Michael will consider all these practices, scope of practices from these institutions, from the state, the hospital they are working in, educational preparation of the person you are going to give to, okay, the competencies and experience. Has the person even done all the in-service trainings that you are going to give? Okay, so you consider all these things. So RN will always assess, teach, and evaluate. Me, I don't like all this stuff. Okay, LPN will do stable and unstable every day. LPN routine. Okay, then UAP, activities of daily living and routine care. So let's continue. We know the RN does all the art pie. Okay, is it about assessment? RN is your job. Is it about diagnosis? We've gone to do assessment. We want to diagnose it. RN is your job. We want to plan for this patient. RN is your job. We want to implement. RN is your job to draw the plan for implementation. Take note and ensure that the work is implemented. Do we need to evaluate? Okay. The healthcare assistant has gone to bath a patient. We want to evaluate if the bathing was done because the patient has skin conditions and we need to bath the patient twice daily. We need to evaluate the care plan. If the twice daily bathing was done, what do we do? Whom do we go to? We go to the RN. And the RN should ensure that the patient is bathed twice daily. So RN will tell the UAP that, hey, bath my patient for me twice daily. Simple. Don't go and do on the ward. Don't go and do, I'm 20 years RN and the healthcare assistant is 50 years. She is old enough to be my mother, so I will not send her. It's a lie. See, they will seize your pin. Close your eyes on the ward. Send everybody you want to send. That is why you are the nurse. Okay. Because if it was you, they will send you. So you to send you. We Africans, when we travel, we are too respectful. we are too, we are too respectful. Yes. That thing has me like this, it has vanished from my eyes. I will send you. you can be working with a stick. Once the hospital HR has cleared you that you are fit to work, I will send you. You see, yeah, I need to send you. So that is it. So so RN does the planning, everything. Okay, so RN's work is not that much. RN will always care for the unstable patients. So RN does the ADPA. Yes, Eunice, shoot. Your hand is up. Okay. So this is the RN. Okay. So and a patient develops sudden shortness of breath. Who should assess the patient? Assessment is for RN. You cannot delegate it. You can't delegate it. Take note. Go to LPN or LVN, licensed vocational nurse or licensed practice nurse. Remember, there is an L in front of their rank. So they are licensed. Okay. Okay. So the LPN or the LVN cares for stable patients with predictable outcomes. What are some of the predictable outcomes? The patient's vital signs are stable in such a way that everybody on the world knows that tomorrow this patient will go home. Does the patient has comorbidities? Yes. The patient is hypertensive, has a history of hypertension, COPD, MI, that history. Once you hear the history, they've had it before, but it has been stabilized. Okay, so now the patient is stable. Okay, and in despite the stability, there is also a predictable outcome. Let's give this patient to the LPN to treat or to manage. Patient with a history of hypertension needs to take tablets for antihypertensive. We can give it to LPN because she is licensed to do that. So oral medications, IM, subcut, according to state law, as I've put it into brackets. If the state you are in does not allow the LPN to give it, don't say because they are licensed, you will. So if you want to be a nurse, you have so many things to learn. The state you are, there are laws governing your job. The hospital you are, there are policies governing your job and governing all this delegation. You should know. If you don't know, Google. You are not encyclopedia. We have internet everywhere. Google. The LPN can reinforce teaching. Okay. So the RN will always start the teaching, the education, but the LPN will reinforce it. Okay. Example, the RN will say, this is how to inject insulin. A patient with type 1 diabetes, okay, has been discharged. He is going home. They have prescribed long-acting insulin, okay, lengthy, for this patient. The RN is supposed to do the education that this is how to inject this type of insulin. If the LPN wants to educate, how should the LPN go about? The LPN will ask the question, can you show me how you give yourself the insulin? So if the LPN asks this question, it means the patient has already received an education. Okay, good. Wound care, dressing wound and ostomy care. patient stability, they can give it. Okay. Then catheterization. Yes, some states allow, please, I'm coming. LPN, some states allows them to manage Foley insertion and straight catheterization. These are two procedures. They are not the same. Okay. But some states does not allow them. So note the state laws. Tube feeding, they can administering feeding tubes, okay, of tube feeding. Stable patient, hypertension, diabetes, post-op 2 days. Okay, they are stable. If they are stable, LPN. What LPN cannot do, they cannot perform initial assessments. They cannot create care plans. LPN review. No, they are not supposed to even review care plans. Perform discharge teachings. They are not supposed to evaluate outcomes. They are not supposed to care for unstable patients. So you are working in a care home. You are on the top floor and the RN is on the down floor. Okay. LPN. A patient on the top floor fell down and the patient is taking blood thinners. Or let me even take that one out. Is it the duty of the LPN to manage this fall? Patient is unstable. No.
No, sir.
The LPN should call the nurse, come and assess this patient and manage. Okay. But in care home, we see otherwise. Most care homes. So the question is, which patient is appropriate for the LPN? Answer this one. Sharp. Let's move.
Stable patient receiving antibiotic.
Yeah.
Stable patient
C.
receiving antibiotics.
Antibiotics.
C. Okay. Good. Perfect. So stable patient. UAP. The good thing about UAP is what I've highlighted. Ask yourself, is their procedure, is their tax routine? Is it non-invasive? Is it activities of daily living? Yes, then they can do. So these three things, write it down. Is it routine? Is it routine? Routine as in activities of daily living? Oh, okay. So a patient has been discharged or a patient on the ward, they take their own long-acting insulin. Okay. Every night they will take a shot, let's say 20 units. This is a routine activity. Let's say the patient is on a care home. Okay. It's a routine activity, but the next check mark you have to do, is it invasive or non-invasive? This is invasive. Okay, UAP, you can't do it. Okay. So this routine comes with a sub explanation. A lot of people, when they see the routine, they think every procedure, okay, yes, they can't do it. And the next thing, is it activities of daily living? Okay, a patient with skin infection needs to be bathed twice daily. Okay, twice daily. Okay, is this a routine care? Yes, it's a routine care. Is it invasive or non-invasive procedure? It is non-invasive. Check mark. Is it activities of daily living? Yes. So all the three has been check marked. Okay, I can give it to the UAP to do. If you don't know these three things I've highlighted, you can never answer any question for UAP or CNA. A patient's temperature or vital signs need to be checked. Is it a routine care? Yes. Is it invasive or non-invasive? It is non-invasive. Is it activities of daily living? Temperature checking. I need to check the temperature of the patient's body. Yes. Okay. So the UAP can do it.
Please, before you move further, in a critical condition, whereby the patient is in a critical condition and is this temperature routine can be assigned to healthcare assistants, or the nurse can go on and do that by herself?
You answer her. He said in a critical condition.
Yes.
Can temperature be assigned to
Or let's say observation generally?
No.
Observation.
No, please. That is the
Observation
work
is a big
of the RN.
word. You say unstable. Once the thing becomes critical and unstable, LPN does not even have the right to do top of UAP. Please, do you understand?
Okay. Yeah.
If the nurse delegates for them to do in that critical condition and there's any trouble, the nurse will be in trouble. Because they were not supposed to delegate because you use the word. That's why we have a ward on the hospital called critical care unit. When you go to ICU, do you see LPNs there? Do you see healthcare assistants there? They are not allowed to come there. So activities of daily, this is a normal thing, bathing, feeding, all this, and this is non-invasive. It is also routine, so they can do grooming. Okay, vital signs routine. Okay, non-invasive, they can do intake and output, measuring urine is routine. I mean, they can do recording fluid intake. You want to give somebody 200 ml of water cap. Yeah, you can record it. It's non-invasive. Ambulation, assisting with walking, repositioning in bed. Okay, 2-hourly repositioning. They can do specimen collection. Okay, we collected urine and stool. You took the patient to the bathroom. They weed. We gave you the bottle, collect it and bring it. Okay, you brought it to the nurse. The nurse will label, do everything, take it to the lab. You took it to the lab. Yes. So you can do. They are not supposed to take blood. It's an invasive procedure. Okay, so that invasive. So these 3 check marks, if you never forget it, I'll be very happy with you.
Sir.
Yes. Yes, Dave.
The power aspect, I miss it crowd. I don't know if you find a day and then recap it for us. Maybe tomorrow when we are starting, we do some
I'll do some refresher
for us.
Okay, so go and read about it tonight. Then tomorrow it will be a 2 minutes quicker. A quickie. Okay.
Thank you, sir.
Bed making. It's non-invasive. It's a routine thing. Okay. Yes. So I can LPN can UAP can do. I mean, don't worry yourself with UAP. They cannot assess, they cannot teach, they cannot evaluate. They are just helpers. Okay. Interpret findings and perform sterile procedures. So one day we went to work. We were plenty nurses. Okay. And they said some should go home. This thing is very normal in the United States. When you are more than the patients and we do the ratio, they will say some should go home. So some went home. Then I told the manager that I want to be UAP for the night. One nurse came to me. A patient needed oxygen because when he sleeps, he will be, I think he has OSA. So when he sleeps, then the oxygen is desaturating. So I want to tell the nurse that, your patient is desaturating. And I suggested to the patient, the nurse, that give oxygen to the patient. Okay, and call the doctor that this is what you've done. The nurse told me that I should go and set up the oxygen. I told the nurse that I cannot do, like jokingly, that I am the UAP. The nurse is saying that, am I also not a nurse? And I told her that the shift we are doing now, I am UAP. If we go to court, my assignment for the night was UAP. So please, I cannot set. She got angry. Did I do the right thing or not?
You did
Yes.
it right.
You did, though. That place is not Ghana.
You are even saving him. He the one that is delegating. You are even saving him. He doesn't know. He didn't
He
say
even
anything.
wanted to
No, she
finish
was
his
of the
wrong.
concern that Abi me too, I'm a nurse. So why is it that I
This
have
always
suggested?
happen in my trust too.
So these are some of the things that you can meet. Your friend, colleague nurse, sometimes when you go to work, you'll be helping each other. They say, oh, go and set up this. It will happen to all of you when you come. Sometimes you go to work, we are more than every hospital in US experiences this. Sometimes we are more than patients. So they'll tell some to go home or they'll reassign you. So if they reassign you, and some of your colleagues will be like, Abi, all of you are friends on the ward. So can you set up this IV for me? Can you do this? You should think about it too. Okay. So which task should be given to the nurse? The answer is C, ambulating a post-operative patient. Okay. Yes. Then so these are the things the UAP does. Okay. The 5 right of delegation. I've shown you the quickest way. If you don't want it, you want the normal right of delegation. That is it. The right task. I want UAP to help this patient to ambulate. Yes, Dave. Okay. Safe delegation requires all 5 rights. So you should know that. Okay. So is it the right task I'm giving to this person? You should ask yourself. Secondly, is it at the right circumstance? Like our sister said, patient with critical condition, vital signs. In that environment, that circumstance, we are in the critical stage. So don't give it to UAP. The patient's condition must be stable before you give it to what? LPN. Okay. The right person, is this person qualified and competent? Have they done their training? That is why the nurse manager on the ward should ensure that everybody does their computer training. their in-service training, the online training. Okay, LPN has passed NCLEST. She has been employed, but she has not done what? CPR training. A patient had cardiac arrest, and you told the LPN to do CPR. Who will be in trouble? If the patient's relative take the matter to court, they will come and inspect this online training. Have you finished your online training? Yes. Okay. Or no. If no, you are in big trouble. So nurses, okay, we work in a very dangerous environment where the LPN, who are you to even go and ask the LPN that have you done this training? That's the issue. So delegate to someone qualified, but you can ask the manager. Okay. That's why you need to communicate with your manager. So the next one is what? Is it a right direction and communication? Okay. So provide clear instructions, please. Right communication. Don't say this is me, this is my mama. Okay. I am from the same country with this woman. This woman has been in the US for 15 years old. Me, I just came. I'm a new nurse, international nurse. This woman is 65 years old. How can I tell him to take this patient to the bathroom? Okay. Especially those who go to care home. You meet problems of this. Language barrier, communication, right direction, right something. Okay. So what they should do, when they should do it, when you are doing your delegation. Yes, LPN can give oral medications in stable patients. Okay. LPN, their denominator is stability. Take note. Then what findings they should report. So these three things. I am sending you to go and change the diaper of this woman in room 1. When should you do it? That's the instruction. I've given the instruction. When should you do it? Please make sure 6 a.m. in the morning. Okay, it is changed. What findings should I? When you are changing the patient, check the bum to see if there is no redness or skin break. Come and tell me. Okay, that is it. More example, please obtain vital signs 4 hours and notify me immediately if the systolic blood pressure falls below 90. But you should, sometimes you should not be super disrespectful on the word. Okay. So you can be playing with them, sending them coolly. Okay. Yeah, that is it. They will do it for you. Supervision and evaluation. So your RN remains responsible for all the outcomes. So blood sugar checking. Okay. The UAP measures blood glucose of 45 milligrams per deciliter, hypoglycemia. She came and sat down and was chatting. Okay. You did not tell anyone. Yes. So the nurse must check how much was it. Okay. Evaluate the results, intervene appropriately, reassess the patient. So delegate assessment, teaching your advice and everything. Unstable patient, never initial assessment, don't. Okay. So all these ones are for you, the nurse, to do. Okay. The UAP is there to help you. What help? With hygiene needs, elimination, movement, personal care. That is it. So if you forget anything, don't forget this acronym, HELP. I'm helping you. I told you the work on the ward is for the nurse. So they are there to help you. So please, which part should be given to the UAP? Laughing.
David,
A
I
stable
expected
patient.
both of you up by 9 o'clock after washing plates.
Okay. Which patient should the RN assign to LPN? One, stability, diabetic, receiving oral medication, like somebody asked on the chat box. Okay. Yes, Mama will bath patients for us. Next question, which patient should the RN see first? Who answer for us? This is priority. You have delegated all these patients to yourself.
Patient with blood
Patient
glucose
with glucose of 35
milligram per
Glucose of 35, a stable hypertensive patient, a patient awaiting discharge, patient requesting pain meds. Okay, so you go for your blue. You use the Amasa. Use the Amasa. You do your check marks. You go your way. Please mute yourself if you are not contributing. Okay. So the fourth is the ethical and legal principles. It is 1:49 at my end. Let's use the last 20 minutes to finish this. Then we say bye-bye. Okay. Right. I'm coming. Okay. So let's look at the ethical. The nurse as a manager should know the ethics around whatever she is doing and the legal backings. Okay. So the autonomy, beneficence, more efficiency, justice, this ones you already know. So I'll just brush over. Okay. Autonomy means respecting the rights of the patients to make their own healthcare decisions. Okay. So adults have the right to accept treatment, refuse, or make healthcare decisions. That is autonomy. The ability to make. Competent adults have the right to refuse any treatment, even if refusal may result in death. Competent, that's the key word. Okay. If the patient does not have the mental capacity and they refuse care, act as a nurse. Okay. Beneficence, doing good and acting in patient's best interest. Okay. Benefits, promote health and well-being. Everything you do for the patient should promote health and well-being. So I administered pain med to relieve what? Suffering and promote health. You're teaching a diabetic patient how to prevent complication and promoting health promotion, performing CPR during cardiac arrest. Okay, you do good. Good. Do not do any harm. When you're doing good to me, don't create a space, a little space to pass through and do harm to me. Yes, you were coming to give me pain medication because I complain of pain. That is a good thing you were doing to me. But what is the bad thing you did not do or you did? The bad thing you did was that you did not check my allergy status. You see why a lot of people fall into trouble? Yes, you did beneficence, but at the same time, you did malfeasance. You did malfeasance. So you are coming to give me what? Pain meds, but you did not check my allergy status and you gave it and I reacted. So you have done what? Bad to me. Preventing injury or unnecessary suffering. As an example, verifying patient's identity before medication administration or using side rail to prevent falls. Okay, do not do any harm to me. Stopping a medication when a serious allergic reaction occurs. Yes, you are doing good to me. Do not harm. Okay, so these are all comparable tables. Then I'm rushing through because you already know the justice. Justice is fairness and equality, equal treatment. So no matter their race, creed, color, politics, patience, everybody should receive fair treatment. That is why on the hospital staircase, those people who are not disabled will walk and go. But beside the staircase, we make another walk away here where people coming with wheelchair will also pass through and go. Those of us who are walking with a walking stick or crutches, we need to get a handrail here. So fair and equality. Yes, Dave.
Please, with this justice, I want to use the foreigners as an example. For instance, where I live currently, you could see Cote d'Ivoire people having Ghana insurance, accessing the Ghana medical facilities. While Ghanaians are there, they don't even have the insurance, or some of them, when they have and it's expired and they come because of the cost involved in the treatment, they refuse to come. But here is the case. Someone from Cote d'Ivoire will come with insurance, we give them the treatment. Sometimes they will not even have the insurance or can we still give them the treatment, neglecting our own. Where do we place this kind of justice?
Somebody should answer this.
Is the system working fair? Is the system working fairly on behalf of the citizenry, or it is working fairly on behalf of the non-citizen personnel?
The system is fair. The system will always be fair. The question we must ask ourselves is, one, are the citizens ready to apply for health insurance and use it? Okay. Two, those people at the health insurance office, okay, which people are they giving them insurance card and which people are they not giving? The people they are giving them, are they paying any bribe to them or not? That is where the problem comes from. The system is always fair because the president sitting in the castle or the health minister sitting at the health ministries, they have done the policy to cover everyone free health care. Okay. But citizens can decide, I won't take it. And the health minister cannot do anything, or the health ministry. cannot do anything about it. So you see, it's not like the system is preventing citizens at the border from getting it. There is so much. I mean, so many things goes into it. Okay, maybe was a strange. Okay, yeah, because if you are a resident of a country and you have your legal status to live, no country will make plans that somebody should come and live in my country without falling sick. They're sick. That's why they do. When you go to UK, we pay all this health surcharge, even if you are going to school. Health surcharge, insurance, national insurance, and all these things. We pay. Okay. Whether you are coming to school or whatever, you pay. Even if you are going for visits in another country, you need to do health insurance policy, travel insurance to
Hello,
cover
sir.
you.
Sir, this one, it isn't that the people are living in your country. They just blatantly refuse to attend to their own hospitals, and they find means and ways to come to Ghana and then send to Cote d'Ivoire, and they are assessing the facility with our insurance, SAS. Even Fulanis and all those things, they are having our cars. You know about this. You understand? And they are even those who come to torment us in the wars. They are even the people who are tormenting the health personnel in the wars.
And then maybe the immigration officers at the border should check those things, and also the law enforcers, the police. Okay. Yeah, because I think if those things were working well.
If I may say something, in that case, you can't stop taking care of them when they come, irrespective of their inability not to access our healthcare. They are sick, they've come. So we just have to treat them. Let's have the notion of the human being, not because of the nationalism or because of the place they come from, and so they don't deserve to have the free healthcare system. But as far as they've come, treat them. Then later, if you want to report to the immigration status, then you can report and let them know that these are some individuals who do come, so they can patronize their healthcare system. I think that's what I would say. But you cannot drive them away in their sick state when they come. Thank you.
Yes, it's very true. Because in the United States,
yeah, just like we can't drive South Africans away, Abby. To accommodate them while they are sucking us, Abby.
Okay, let's continue. 2 patients arrived. One is having a minor injury, other one is having severe hemorrhage. Resources are directed to the patient with severe hemorrhage because of the clinical need. Maslow. Okay, this demonstrates justice and fairness. Okay, like our brother said, Mr. Wuni said, okay, you can't say because of their immigration status or because of their creed or color, you're going to deny them. No. Okay, that is it. So a country like USA, when you enter any hospital, no matter what, they will treat you. They will not even discuss medical bills with you in the hospital. You will come home. Then the hospital finance guys billing people, they will send you a letter with your bills. Okay, if you don't have insurance. Then you now go into agreement with them that a payment plan. Okay, a payment plan with them. Then you'll be paying. That does not mean that next time when you are sick, don't come. Come. They will still do more payment plan for you. That's it. We don't deny anybody health care because the person was not part of us. That is justice, is fairness. Then fidelity is what? Keeping promises and maintaining commitments. Fidelity. building trust. So a nurse promises to return in 30 minutes with pain medication, and that's so. Following through on patient's requests. So fidelity has been what achieved because the nurse kept his or her word. That is fidelity. Okay. Then the nurse also tells the patient, I will return after lunch to discuss your concern. The nurse returns as promised. So fidelity has been achieved. Okay. Let's look about veracity. The difference between fidelity and veracity. Veracity is telling the truth, being honest. Okay, being honest. Okay, let's look at examples. Explaining a diagnosis honestly to a patient. Okay, you have shown what? Veracity to the patient. Disclosing medication side effects to the patient for him or her to make the judgment whether to take or refuse. Some people will go and sign the MA charts before they take the medication to the patient. So by force, patients should take it. Otherwise, they will be in trouble. So they will hide information from the patient. Then reporting a medical error according to policy. Okay, being honest to the system. You made a medication error, being honest. So veracity is truthfulness. Okay. Patient, will this procedure hurt me? The nurse responded, you may feel some discomfort, but I will explain how we can help manage it. This demonstrates what? Veracity. Okay. Yeah. So these are the ethical principles you should know. Okay. Then we also talk about informed consent, voluntary agreement. Okay. The patient must be competent, understand the information, sign voluntarily, have decision-making capacity. So somebody cannot come to the ward and pick your patient to the theater for surgical procedure without letting you know, the nurse in charge of the patient. Because you, the nurse, you should check mark. Is my patient competent? Did she or she understood the procedure that is going to be done for him or her? Sign the consent and have also decision-making capacity or mental capacity. Okay, that's it. So you are not, the nurse is not supposed to explain the surgical procedure or whatever procedure to the patient. Your own is to verify if the patient understood, if it has been explained to her by the provider concerning the procedure, the risk, benefits, alternatives, and consequences of refusal. It is the doctor or the surgeon or the provider's duty to obtain consent. And it is the role of the nurse to witness the signature, verifies identity, confirms consent was signed, ensures questions have been answered. So just this year, one doctor had an issue that he mistakenly went to remove somebody's liver instead of the spleen. Okay. And the patient died. And the doctor was arrested. The question is, what was on the consent form? This issue happened in the United States. Okay. So take note. Who was the nurse in charge of this patient? All these people will be called to court. Okay. The The nurse does not explain surgical risk, obtain consent, or coerce patient. Okay. So patient says, I don't understand why what this surgery involves. The nurse should notify the surgeon. The nurse should not explain the procedure, him or herself. In emergency situation, we call something implied consent. Yes, an accident has been rushed. Patient has been rushed with motor vehicle accident to the ER. Somebody has got fracture of the femur with the femoral artery torn and bleeding. We need to go and do emergency operation, orthopedic surgery. The patient is unconscious. We don't know the family of this patient. Should we allow the patient to die? No. So we have a certain type of consent we call implied consent. It is given to unconscious traumatic patient or cardiac arrest patient. So treatment may proceed without written consent. Okay, the doctor will give the go ahead. Let's go. A patient arrives unconscious after MVC or MVA and needs emergency surgery. Can surgery proceed? Yes. Reason, this is an implied consent. Okay. Okay. Advance directives is another thing. This is a legal document that communicates a patient's wishes regarding future healthcare decisions. So now I am talking, I'm doing everything. I can see a lawyer or I can see any court, whatever, and make a future plan. That in case I become incapacitated, this is what should be done for me. I am giving all my power of attorney to this. I am giving my whatever will to this. So the purpose of this advance directive is to protect patients' autonomy to make decisions when the patient can no longer communicate. So types of advance directive, we have a living will. The living will specifies treatments the patient wants or does not want. Example, do I need mechanical ventilation? Yes or no? Tube feeding in case I become unconscious? Yes or no? CPR? Yes or no? Dialysis? Yes or no? So in UK, they call it what? Advanced care plan. Advanced care plan. US, they call it living will. Okay. A patient states, I do not want to be placed on a ventilator. It is a will. This is documented on a living will. In UK, they have a form, advanced care plan. You draw it there. Okay. You can draw, everybody can draw. Go and see your doctor. Draw advanced care plan, put it on your phone, give it to your family members if only you wish. In case something happens to you, this is what you wish to be done for you. Nobody should do CPR for me. Nobody should put me on any ventilator, whatever. Call it living will. Now, this type of advanced directive is what? Power of attorney. So power of attorney, the patient appoints someone to make healthcare decisions if they become incapacitated. And the healthcare decision is about one, finance, and two, health. So we have power of attorney to health and power of attorney to finance. Okay. So finance, I have plenty money in my bank, but in case I become demented, that I don't remember the past again, I become unconscious. Okay. I give all the money to my brother. So if the hospital or the care home needs any money for my medical bills, it is my brother who will make the decision whether, listen, when the money should be released or not. If my brother says, no, this money, this thing, forget, I agree. Okay, yes. And the same thing, power of attorney to health will make decisions. We want to remove you from the life support. We want to pass catheter for this patient. The power of attorney for health will say, no, I don't want you to pass any catheter for my mother or my father or my brother or my friend. Yes, people give power of attorneys to their friends. I have seen patients who have given power of attorneys to their granddaughters, grandsons, and all this. Yes. Nobody tells you whom you should give power of attorney to. You make your own choice. But make that choice before you lose your mind. Because once you are incapacitated, the hospital will make decisions for you. Okay. So a patient designates their spouse as healthcare proxy or power of attorney. If the patient becomes unconscious, the spouse makes the decision. Simple. So the spouse will come to the hospital that they have the power of attorney card or letter from the court that, and there's nothing the nurse can do. Okay. Then another type is the do not resuscitate. The do not resuscitate goes for CPR. So a provider's order indicates that CPR should not be performed if cardiac or respiratory arrest occurs. Okay. So the provider will make the order. They will discuss with the family that this patient that came has heart condition, has liver condition, has this, has kidney failure, has all these comorbidities or medical histories. So this patient with all these organ failures, okay, or organ problems, if they should get cardiac arrest, I don't think even if you resuscitate him, he will come back to life. So let us just make a decision. Let's write an order that there should be no CPR, no chest compression, no defibrillation, no intubation for resuscitation. Okay, we call it or do not resuscitate. US they call it DNR, but in UK they call it DNAR. Do not attempt resuscitation. Okay, I don't know why these two countries want to choose their own English. Do not resuscitate me means stop, does not mean stop all care. Okay. Yes, I have become an incapacitated patient in your care. Do not resuscitate me does not mean stop, don't give me oxygen. Patients still receive oxygen. Patients still receive pain med. Patients still receive their comfort care or comfort measure. Every dead, dying patient receives comfort measure. We have some care homes or some homes, we call it comfort care. Medical surgical ward in hospitals, they call it comfort care. Patient has been brought there to die. We call it comfort care. So you are nursing them to a peaceful death. So you give all your pain meds, your opioids, your oxygen, all these things so that they die peacefully. Yeah, antibiotics and all these things. Okay. Do not resuscitate. If you give somebody antibiotics, this is not CPR. If you give somebody pain med, this is not CPR. If you give somebody oxygen, this is not CPR. So it is not part. Okay. Palliative. Palliative is cancer. Palliative is only for cancer patients. Okay. Yes, but comfort care is for every other patient, including cancer patients. Okay. So patient has a DNR order and develops pneumonia, very bad pneumonia, COVID-19. The nurse should still administer prescribed antibiotics. So DNR means no CPR, but DNR does not mean no treatment. Take note. Okay. If patient's family requests, they make a request and it conflicts with what the patient has done so many years or months or weeks ago, it conflicts with the advance directive. The hospital has the right to follow the patient's wishes. Okay, so the patient's documented wishes takes priority. Take notes. So patient made a will that if I die, I am donating my liver to the bank, to the National Liver Bank or donor bank. Then the family will say, no, 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 this is not our culture.
Sir.
No, the hospital will still go for it. Yes, Eddie. Okay. Any question? If no question. So this is what you
Hello.
should know. Practical questions.
Hello,
A
sir.
competent, yes. I'm listening. Hello?
Hello.
You're not talking. Okay. Competent adult patient refuses life-saving surgery. Competent adult. What should the nurse do? Yes. What do you think is the answer?
Yeah, you
Shoot.
respect the patient. Respect the patient. What order? That's autonomy. The person doesn't want to do it, so you respect it.
Okay, so you go for option what? B, right? Okay. So respect patient's autonomy. Do good. Avoid harm. Treat fairly. Keep your promises. And always tell the truth. We are done. Okay. So tomorrow when we come, we'll do our model 5. Then we go finish and do model 6, 7. But I'm sending this to you because we will start from here tomorrow. And I'm putting it on the chat box. Okay. So you can, Ayariga, please help put it on the page for me. So be part of this journey, guys. And let us so that is it. Okay. So that is for day 1. Tomorrow we will do day 2. Let me leave you here so that tomorrow we continue. Same time, same venue. This teaching is going for every nurse. Invite your friends to join. If you want the recorded videos, they are on the either YouTube or Facebook. Go and get it. I've sent the slide into you. Okay, perfect. Thank you so much. Now you'll be a master of management of nursing care. Okay, or nursing management. You know how to delegate. You know how to prioritize your patients. You will not fear prioritization again. Go and learn your kill banks. and start getting your AA and 100%.
Amen.
God bless you.
Thank
God
you
bless
so
you.
much,
sir.
sir.
All right.
God bless you, sir.
Thank you very much. Today, dear, one my dream. Thank you very much, sir. Thank you very much. Have a nice day, sir.